Thank you. For day one of the Sickle Cell Disease Summit, 5th annual, as you already know, making decisions today or shaping the sickle cell community for tomorrow with actions through today. I'm going to have our fearless leader, Ms. Lanry, introduce our two speakers for this panel and moderate the session and the Q&A that will follow. So with that, Ms. Lanry, take it away.
Thank you. Thank you, Mr. Hines, and thank you, folks, for staying with us till the end of today. So I have two amazing experts here, and we'll introduce Dr. Madeleine Verhofstadt from McMaster University and St. Joseph's Healthcare, Hamilton. Dr. Madeleine Verhofstadt is a professor of medicine and pathology and molecular medicine at McMaster University. She is the co-founder and former director of the Adult Hemoglobinopathy Program at McMaster University Medical Center and the current chief of medicine at St. Joseph's Healthcare, Hamilton. Dr. Verhofstadt has worked to establish sickle cell disease clinical guidelines with the American Society of Hematology, the European Rare Best Practices Group, the Canadian Hemoglobinopathy Association, and the Ontario Ministry of Health, including the 2023 Ontario Health Sickle Cell Disease Quality Standards. Dr. Verhofstadt is passionate about health equity, public policy, education, and advocacy, and that is Dr. Madeleine Verhofstadt. Not yet, I'm just going to... We also have, all the way from the US, Dr. Julie Cantor. Dr. Julie Cantor is someone that I think, if you don't know her, you're missing out. She's a big shot when it comes to sickle cell disease, especially in the US. She is a lifespan hematologist specializing in sickle cell disease. Dr. Cantor recently moved to Alabama to become the director of the Adult Sickle Cell Disease Program and co-director of the Comprehensive Sickle Cell Research Center. Prior to moving to Alabama, Dr. Cantor was an associate professor of pediatrics at the Medical University of South Carolina, where she developed the first all-ages lifespan comprehensive sickle cell center. Honestly, I love that. And that's what we are encouraging even more now, for a center to have care across the continuum of life. She works closely with national partners, including the American Society of Hematology and the NIH, on both advocacy and research. Dr. Cantor works on the development of novel therapeutics in sickle cell with expertise in clinical trial, endpoint, and trial designs, as well as in areas of improving access to care. Honestly, I can go on and on. I want to also mention that Dr. Cantor is also the president of the National Alliance of Sickle Cell Centers, about 100 or more centers in the US, which is amazing. And she's also involved in gene therapy, and she's done some. So if you're here tomorrow, you will hear more lectures from Dr. Cantor. But without taking more time, I would like to welcome both of our panelists. And we will start with Dr. Verhofstadt, and she will have the podium. Thank you. So you can use this to click and...
Thank you so much, Ms. Lanre, and wonderful to see you all today as we near the end of a fantastic day of learning and connecting with one another. So here are my disclosures, none of which I think will affect the content of our session today. So today we're going to be looking, or during this session, we're going to be looking at comprehensive care, and my focus is going to be on our Ontario setting with some reference to what's happening across the country as well. And Dr. Cantor and I kind of connected ahead of time to try to, so that what I'm sharing with you complements the US perspective that she's going to be bringing. We all know that the sickling that happens within the blood of people who are living with sickle cell disease can cause terrible pain, and as we've been learning and being reminded during these sessions, a whole host of manifestations or issues across the body. And this all comes together into the experience of the person who is living with sickle cell, and this is a beautiful, haunting image from the dearly departed Hertz Nazaire, an attempt that he put together that I think is very evocative, sharing what that experience is like. When we think about system planning for this, we have to recognize the context, not only the context, the medical situation, the science of sickle cell and the complications that can happen, but societally, socially, and as a healthcare system, how this is managed. And when we think about sickle cell, we're often thinking about what are the barriers to care, some of which are very well outlined in this lovely illustration by Dr. Paula Tanabe, where we recognize that someone with sickle cell may have chronic pain and this perception of addiction. There's racism that can be woven through that experience in the healthcare setting, frequent visits that can be happening, clinician and patient knowledge deficits, so we want to make sure that everybody is well educated, and the stigma, and these can all be barriers to care. Alongside that, and as I had referenced on that earlier slide with the illustrations, when we're trying to think about a system of comprehensive care, we need to consider how are we going to address the acute complications, address the chronic complications, and even better yet, do all that we can, build a system that's going to do as much prevention as possible in partnership with the patients and families. So anyone who has seen me present before has seen this illustration. And sometimes when I am sitting side by side with someone in my clinic, I am picturing for them this kind of experience, where sometimes, fortunately not all the time, sometimes those health challenges can just seem immense. Alongside that, and quite horrendously, sometimes those health burdens are having to be faced in an uphill way against health inequities and system barriers. And so when we're thinking about creating a system that addresses those things, let's just look at what's happened in Ontario over the past decade or so. In 2017, there was released the Clinical Handbook for Sickle Cell Disease Vaso-Occlusive Crisis. And I won't go into this in a ton of detail, but it was really a precursor to the Ontario quality standards that we've heard more about today. It was a very focused initiative trying to look at the experience of somebody coming in with a vaso-occlusive crisis to the emergency department and looking at that episode of care and how we could make sure that everybody across the province was getting consistent access to excellent care. But it wasn't enough. And thankfully, we got buy-in from Ontario Health through, in large part due to advocacy from patient organizations, from Sickle and others. And as we've heard about earlier in the day, in early 2023, the Sickle Cell Quality Standards launched. And why do I mention this when we're talking about comprehensive care? Because it essentially helps to create a framework for what would constitute high-quality care across the whole care continuum. So I've bolded here, it applies to all pediatric and adult healthcare settings relevant to sickle cell disease, which is all of them. And it includes screening for and prevention of complications, assessment and management of acute and chronic complications, and use of disease-modifying therapies, right? So finally, in Ontario, for the past, year and a half, we have had this document, and we've been learning in other sessions, and I won't go into a lot of detail in the 20 minutes that I have, but this creates a foundation. And as I was sitting here as we were getting ready to go live, Ms. Lanray came over to me and she said, "You're going to talk about the RRR document, right?" I said, "Oh, I don't have anything on my slides." But you'll see in your program, it's referenced the RRR document. So I think this is a good place for us to pause about the RRR document. The Ontario Hemoglobinopathies Patient Association started working on this, maybe 8 years ago or so, creating a framework that outlined what are the key roles, responsibilities, and ratios for comprehensive care clinics. So who are the care providers who we need? If we're going to say this is a comprehensive care clinic, who are going to be the care providers that need to be in there? And that's a document that's undergoing ongoing evolution. And as I come to some of the other slides, we're going to talk about, okay, nurses and doctors aren't enough. We need social workers, we need physiotherapists, dietitians, and we're going to talk more about that. But these are the elements that are being woven into these quality standards. So the idea is, if we create an excellent system of care, it's going to be offloading those health challenges. Actually, if I was better with my graphics, we actually want to shrink the health challenges because we're catching them early or preventing them entirely, and leveling those health inequities and system barriers, because it's just not acceptable to have patients facing extra challenges over and above their health issues. So we want multidisciplinary care and system improvement to address this situation. All hands on deck. Ooh, this formatting got all wonky. So this is the wheel of the elements of comprehensive care for sickle cell disease. We need lab testing, we need expert outpatient care, we need psychosocial support, patient support organizations like SCEGO and education, transition of care in adolescence, acute care, transfusion support, and diagnostic imaging availability. And that sounds like a long list, and it's still kind of just partial. I'm sure there's categories that we've missed there. A little storytelling here. And I think there was an animation on this that got a little bit glitchy in the transition. So when I've been independently practicing for 15 years. When I started, there was just Toronto clinics, Sick Kids, UHN, and there was work happening at a lot of other places, but it was in not a very well formalized and definitely not in a provincially funded way. When in 2013, we launched our Lifespan Sickle Cell Clinic at Sickle Cell and Thalassemia, so it's called the McMaster Hemoglobinopathy Clinic at McMaster Medical Center. And at that time out in London, there was formalized pediatric care, but not adult. So it's been a very interesting journey. I think it would fit well into kind of creating a timeline. I'm looking at Lanre as I say that. It'd be really nice to put together a timeline of when all of the comprehensive care clinics came on board. Oh, that part of the animation was working. There we go. Okay. And I didn't mention Brampton, but Brampton now has a formalized clinic, as you'll see on an upcoming slide. When we're developing a comprehensive care clinic for sickle cell disease, I've got listed here some of the key providers. Nursing for sure, plus a nurse practitioner if possible, social worker for sure, specialty hematologist, physiotherapist, dietitian, admin support, manager and kind of administrative support, healthcare aides, psychologists, pharmacists, peer workers, and navigators are some of the multiple interdisciplinary team members that can be beneficial team members. This is a snapshot of our team, and the team is always constantly in evolution. So we've actually had one team member join the team since this slide, but many of the folks are over at that table over there. Just shout out to the McMaster Hemoglobinopathy Clinic team. Another really nice way to look at this, and while we're giving shout out to Dr. Cantor. This is from a paper that she and others put together looking at what are the essential components of that comprehensive care team, then what's optimal, kind of to add on as another concentric circle around that, and what can be helpful adjuncts. And I think this is all a little bit up for debate, right? So for us, now that we have a physiotherapist on our clinic team, this is in the essential category. We can't imagine not having a physiotherapist, right? But is it absolutely necessary to, the core elements of looking after the medical aspects of sickle cell? A lot of it depends on what else is available in the community, in the healthcare system. But I would encourage all of you to have a look at this paper because I think it's really extraordinary. And this is another image from the paper. This looks at how do we classify the models of sickle cell disease care. And the classic comprehensive care clinic is this standalone clinic space. It's much like the clinic, like the red blood cell disorder clinic at Toronto General. They have their own clinic space, they have their own team, they've got their own, like the team, they're not pulled in any other directions, they're just there for that. And this model has historically worked well in urban areas where there's high concentrations of people needing those services. In other places, and I think our program is a little bit like this, it's an embedded care model where the resources are shared within a larger program. And I guess maybe that's how our program started out. I'm looking at Jen, she's one of the longest standing members of our team, along with myself and Dr. Athale. And when we started, we were part of the pediatric hematology oncology program. And you can imagine how that was kind of around a round peg, square hole, or whatever situation, because we had our adults coming through and nobody was used to seeing adults, and we had much different needs and much different access to resources for the patients and families coming through our program compared with the pediatric oncology, which in Ontario anyway is probably historically the best resourced. And then we were looking at care for adults with sickle cell, which is probably historically the worst resourced, and it was almost like a culture clash. We're still part of the pediatric heme-onc program, but as time has evolved and as we've increased our directed funding for more of a classic comprehensive care model, we've now been able to build our own team, and folks are less pulled in the direction of the other situations. I will also, I'm going to just quickly skip over the specialized medical home and highlight we also are somewhat of a hub and spoke model in our program, and I'm going to show this in the next slide. So when we launched the clinic, we realized that our McMaster University Medical Center serves a huge geographic catchment area for specialty things. And included in that were the centers, I hope that this comes up if I click it enough times. Maybe not. So Kitchener, which you can see in the upper left corner of that oval, and St. Catharines in kind of the lower right in the Niagara area. So we have increasingly over these years been able to build very strong partnerships with the general hematologists at Grand River Hospital in St. Catharines, or in Kitchener, and at the Niagara Health System down in St. Catharines, where now folks who live in those areas can go to their local hematologist and get most of their care there, and we're there for once or twice a year check-in, we're there if questions or concerns come up in the meantime, and this is all part of trying to be patient-centered, person-centered, and minimize the burden of medical appointments and travel for folks. There we go. A quick moment on the role of primary care partnerships. Won't be a surprise to probably anybody in this room if you live in Ontario that there's a primary care shortage, and even folks who have tried very hard to get connected up with primary care, whether it's a family doctor or a primary care nurse practitioner, may have struggled. Many of the times folks are coming into our clinic, we're asking them questions about, have you had again, this is the adult clinic, have you had a pap smear? Are you up to date on your vaccinations? They may have questions about these primary care issues, and it's really, really important for folks to be plugged in. I've got outlined here a number of the reasons, in addition to those that I've shared, that this is very important. And that was a gap as well when we first started, and over the past, I would say, year and a half, we've had an increasing strengthening relationship with one of our community health centers, Hamilton Urban Core, and we were delighted to participate in an education symposium day that happened last year alongside them, as well as the Refuge Center for Newcomer Health in Hamilton. In Ontario right now, this is kind of the landscape. This is an Ontario Health slide. So the purpose of this slide was to highlight new funding that came in. So you'll see on the right-hand column some new funding that came in. Increased, so new funding for Windsor Regional Hospital, which is really exciting because geographically they've had a bit of a hub and spoke relationship going with London Health Sciences for a while. But if anybody's driven that highway, they're not actually that close to one another. And so now they've got the local expertise to deliver both pediatric and adult sickle cell care in Windsor, and the funding for the interdisciplinary team, which is really exciting. Lake Ridge Health as well. I'm not sure if Karen's still in the house. Karen has been a huge advocate for Lake Ridge Health and all of the building they're doing out there. Trillium Health Partners in Mississauga, which is a huge epicenter and a huge geographic center for folks with sickle cell. And historically, anybody living in that area would have to be driving to Brampton or Hamilton or downtown Toronto. And now we've got funding for a program there. William Osler in Brampton, Scarborough Health Network, enhanced funding for University Health Network, which we've referenced, and really exciting. We're talking about a very dense geographic area here in Southern Ontario, but what happens if you live up in Sudbury or north of there? We still want folks up in that region to be having access to expert interdisciplinary comprehensive care, and now finally starting this year, that's launching. So I'm going to fly through the last 2 or 3 minutes here. My wheel got all wonky in the transfer of the document, but you get the picture. And we've said, okay, it's fairly simple. There's these 8 aspects of the wheel of care. But then where the inequity can really be is in the details. So what's in the boxes on the outer ring there is just a partial listing of the breakdown of what all the elements are. So for example, when we launched our program in Hamilton 12 plus years ago, we didn't have access to liver MRI specifically to look at liver iron concentration for people with iron overload. So those folks, we did sort of still have access. They were having to drive up to Toronto, and that was an inequity, right? So we could get it, but it wasn't easy, and now we've got that. So what about Health Sciences North? Do they have that? Do they have apheresis? Do they have access to expertise in chronic pain? Not singling them out at all, but just as an example, every time we're bringing on a new comprehensive care program online, we want to be thinking about these things. Post-discharge planning and follow-up. How well linked in are people when they are leaving the emergency department? Is anybody checking? Have you been connected with the local comprehensive care clinic? Okay, yes, you have. Let's send them a notification that you've been here so that they can reach out to you tomorrow or next week or 2 weeks from now. Make sure that you've got a clinic appointment. So there's all these proactive things, and the excellence is in the details. Psychosocial support as well. We've talked about social work, but what about some of these other teams? What about spiritual care? What about palliative medicine teams? There's a lot of stigma or preconception connected to palliative medicine, thinking it's just end of life, when really the palliative medicine world has been undergoing a huge revitalization and looking at themselves as really experts in management of a complex chronic illness and in symptom management, right? So at our local hospital, they've been huge allies and partners. And then as well, what's the role of peer support? Peer support through the patient organizations, peer support as part of the medical team. Complex pain, I've got a couple of slides, but I'm not going to go into details. It becomes a huge challenge for someone. So we are optimized on hydroxyurea, or so you're optimized now on transfusion. What about the complex chronic pain, and who's going to help someone with that? Because it can be very challenging on a day-to-day basis. And there's a lot that can be gained from being connected in with expert teams. And lastly, I'll just highlight, this is both for acute, so you've had something very serious happen with your health, and you suddenly need a full blood cell exchange on the apheresis machine, which is pictured here, or on a chronic basis. Some people benefit from that as a modality of chronic transfusion. Who has access to that? Where is it available? Is it available after midnight? Is it available in an emergency? And when we're thinking about geography of a province as vast as Ontario, what happens if you're in Thunder Bay and you need this treatment? Do they have it in Thunder Bay? I don't know the answer. If they don't have it in Thunder Bay, what's going to be considered the quality standard for the timeliness of getting that person? So these are the system things. I know Jennifer Bryan is around. She's got a lot of weight of responsibility on her shoulders as the provincial lead for sickle cell, and these are the things that we're really thinking about in terms of ensuring consistency of excellence. I will mention, again, we'll zoom out a little bit, but not beyond the southern border in my part of the talk. CanHeme, Canadian Hemoglobinopathy Association, has also been thinking about these things and working on these things for a long time. The sickle cell guidelines from 2014 are about to be updated, and there will be further updates, but I'll mention, you'll see at the bottom of that list there, the very last and kind of leave with gusto chapter is comprehensive care centers. So, thinking about the quality of care. And CanHeme does, in case you or your loved ones, or for those who are in the healthcare workers, have somebody moving, CanHeme does have a website with contact information for all of the Canadian care centers. So this is really important for us to keep in mind. So I'm going to wrap up now. Thinking about all of this, I'll highlight when we're thinking about education and system improvement, we want to target all levels. We're here today, we're meeting with patients, family members, loved ones, healthcare team members, and we want to expand out that education and system improvement up to the hospital level, the regional level, provincial, national, and international. And ultimately, educated, empowered patients and families take an active role in their care and advocacy, and that partnership type of relationship that we've heard about and that Josephine was telling us about in the last session, where we really want to be sitting side by side, hand in hand with patients and families, helping to guide their decision making. So when we have this uphill battle, we're going to tilt that on its side. We want this to be on even ground. And through the collaborative efforts of organizations, team members, and community members and supports, we want to lighten this load. And with that, I thank you, and I'll hand it over to Dr. Cantor.
Thank you very much, Dr. Verhelsek, for that comprehensive presentation. A round of applause for Dr. Verhelsek again, please. And now, Dr. Julie Cantor to the podium. Thank you.
I just want to apologize to everyone up front that you're going to actually have to hear from me 3 times while I'm here in Toronto, and you can bring all those complaints to Dr. Ivy, who I've worked with for many years. So this is the first, and I actually love the order of these sessions because they kind of build. And we're going to start with talking about comprehensive models of sickle cell disease care. And I came to this in many ways, but in part when we started looking at novel therapies, and I mean even hydroxyurea and L-glutamine, it doesn't matter if we have these therapies if we can't get them to the people who need them. And I've probably been thinking about this, God, forever, since I got into medicine, about how we do this and how we make a model that has wiggle room, but is also standardized, right? We want to make sure that if you get care in Ontario, that you get care that's just like that in Alabama. And that care should be able to be transferable, translatable, and equitable. Oh, these are my conflicts, there's a lot. Suffice to say, I consult for almost everyone, and if I like their drug, I might talk to them twice. But I find that the more we work together, the more we get done. And it's something that we haven't done very well, quite honestly, in sickle cell disease overall. And it's really important to me that we change that and that we continue to work really closely together. So hopefully we'll talk a little bit about why I think we need a new model of care and how we've changed over time with the way we manage sickle cell disease. Talk a little bit about what I consider the old model of care versus the new model. And then think about how this applies not just in the United States, but globally. I'll tell you a little bit about the National Alliance of Sickle Cell Centers, which I started with 4 colleagues in 2020, and where we've gone from there, and how I think that applies here in Canada as well. All right, so I think people are pretty familiar with graphs that look like this. Sickle cell disease, we've really improved our outcomes in our pediatric group, and you can see that from that blue line that moves to the red lines. But we're not making a big headway of that peak in mortality in our young adults. And we know it's the most clinically significant hemoglobinopathy in the United States, where it affects at least 100,000. I know in Canada that number is closer to about 7,000. I will tell you in the US, 100,000 is an underestimate. So now that we've done more and more work with data and data analytics, I can tell you we have about 125,000 affected individuals. My guess is that's probably true in many places. In the US, everyone is diagnosed now by newborn screening, but it's only been that way for about the last 25 years. I find this really interesting because I will get individuals walking into my clinic at 54 who never knew they had sickle cell disease. And people say, God, how can that happen? My favorite patient to talk about is a 54-year-old wonderful woman who didn't really have any problems as a child, but as an adult had increasing frequency of discrete pain episodes. And she describes these having no idea what a vaso-occlusive crisis or acute pain crisis is, and says, I had these episodes, they would last anywhere from 3 to 7 days. They would come out of nowhere. I couldn't move, I couldn't function, I couldn't walk, and they would go away and leave me drained, and I would never know when they'd come back. And someone had diagnosed her with rheumatoid arthritis, whatever that means. But here's this woman who is of African descent and anemic, and yet nobody put the pieces together, which just floored me in 2023. Needless to say, we found her, diagnosed her, put her on hydroxyurea, and she firmly believes we have changed her life. My only problem is she refuses to see my nurse practitioners because when she was going through a lot of mess, she rarely saw an attending physician. And I tried to explain her that my team is different. It's a slow progress. So the survival rate into adulthood has improved, but our survival rate of adults has really not significantly improved, and that's where the work needs to be done. And while this is a rare disorder, it's also quite an expensive disorder, which I'm sad to admit is often how we get attention in the healthcare system. I would love to say that our systems care most about individuals who live here, but sometimes they care about how much we cost instead, which is fine. I will speak to that side of the line to them, and in my heart, I know I get to do what's right because it helps that taking care of people well helps save money, so it works out in the end. All right, so we've already gone through this. Sickle cell disease is clearly a multi-system disorder. And I always bring this up just because I've had surgeons in my audience be like, why does this matter to me? Well, my favorite conversation there is one of my first early days in Alabama when I had a patient who'd been shot in the leg, had a gunshot wound, not something you have to deal with all that often here, I'm sure. We have to deal with it, unfortunately, not infrequently. And I called the surgeon and said, we need to talk. And he was like, why are you bothering me? I know how to give blood. I don't need your help. And I said, yes, but you gave the wrong blood. And XYZ is going to happen. And he was like, oh? And I said, and it's going to increase your length of stay. And you're going to have all these complications. He said, okay, I'm listening. So again, reminding people that no matter what someone presents to the system with, if they have sickle cell disease, we have to consider how their sickle cell disease matters. And that not only does it of course, cause multi-system problems, but it continues to remain a very high cause of early mortality. This was a study that was done looking at comparisons of not just mortality, but quality of life and what that looks like. And suffice to say, we can do a whole lot better than we're doing now. So this is my sad history. I saw earlier today in one of the presentations similar versions of this, saying that we've known about this disease, right? We've known since 1910 that there was a condition called sickle cell disease, and yet we have the very few numbers of drugs that are available. It's what I call my sad history or my sad timeline. But at least there are dots on the timeline. And I heard someone earlier today ask about new therapies. If you look on clinicaltrials.gov right now, you'll find there's over 50 new therapies in development for sickle cell disease. And that wasn't there 10 years ago. So we are making progress. It's slower progress than we'd like. But again, I think the more we do together, the more we get done. Okay, but I've proven, right? We're not there yet. We got to do better than we're doing now. So why do we need a new model of care? Well, because the current one isn't working. So why would we keep doing the same thing over and over again? That is actually the definition of insanity. And so we said, okay, we have this problem. We have a disease that limits life. We're not doing as good as we need to. And people get more complicated. We're like fine wine, right? We all get better and more complex as we get older. So we need people to specifically care about this disease in the context of aging throughout the lifespan, not just when people are children. And so thinking of our old model of care, it was truly a pediatric model. And for a lot of reasons, that's because we didn't have children living to be adults with sickle cell disease, so the disease was confined to pediatrics. Unfortunately, that also meant that many of my adult hematology colleagues literally never learned about sickle cell disease in training. It wasn't a core competency for them. And so that left the pediatricians knowing more, even as patients aged, than the adult doctors did. And we know that in high-resource countries, our pediatric care has really significantly improved. A lot of this is newborn screening, but it's also vaccines, which is becoming a dirty word in the US. You're gonna have a lot more Canadians soon. But also the use of TCD, or what we call the sickle stroke screen, right, to identify those people at high risk of stroke. The use of hydroxyurea has dramatically changed childhood sickle cell disease. But the nowhere to go phenomenon was rampant. As people aged out of pediatric care, there wasn't a place to transfer or transition them. And for a long time I heard, well, there's never going to be enough doctors, let's teach our primary care doctors to take care of people with sickle cell disease. And I love you, Dr. Ivy, but it drove me crazy. Because while we have some amazing primary care doctors, most of them are too busy, too overworked, and they just don't have time to pay attention to that 10 people in their 1,000-person panel. But it also bothered me because we don't say that about hemophilia, and we don't say that about cystic fibrosis. We don't even say that about people who are now growing old with HIV, because that's a life condition too. We send them to a specialist, and if there isn't one, we figure out how to get the specialist to them. So why weren't we saying that about sickle cell disease? And I sort of started to feel we were speaking it to existence. The more that we said there'll never be enough doctors meant there were never going to be enough doctors. So how do we fix that? It's a system problem. How do we fix it? Well, even when there were adult programs, there were what I called consultative. And even now, I'll go to my pediatric clinic and talk to the patients and the families and say, have you seen your pediatrician? And they're like, my sickle cell doctor does everything. I'm like, okay, but you still need to see your pediatrician, because we love to say we do everything, but we don't. But pediatrics was very all-encompassing. On the adult world, very little is. You have a knee pain, you go to the ortho. You have an ear pain, you go to the ear doctor. It's this very consultative model where each sort of piece deals with their own problem. And that just doesn't work in a disease that can cause a whole lot of problems throughout the body. So we couldn't just have that. And in fact, when I walked into UAB in Alabama 5 years ago, we were a consultative model. They had clinic once a week. They sometimes had room to treat pain outside of the ER. And if you needed antidepressant meds, you needed to see a psychologist or a psychiatrist. And if you needed birth control, you needed to see the GYN. And as we all know, that meant more people didn't see more providers. It meant more people didn't get the care they needed. So we had to figure out how we brought this all together. This is an example of a patient, because I always like to throw an example in. But she's a 29-year-old with SS disease, and this is, of course, a makeshift, not a real person, but she actually is a real person. I just changed her name to protect her identity. And she was diagnosed by newborn screening. But interestingly, this happens more than you think. She was never seen by a specialist as a child. She was followed by her primary care doctor in South Carolina until she became an adult. And by the time she got to me, she actually had more alloantibodies in her red cells than I had ever seen. Severe avascular necrosis, and a lot of pain. And she tried hydroxyurea, didn't feel it was for her, didn't know why she should take the medicine. So Janelle is why we needed a new model of care, right? It's not just about where you live. I treated 5 other people in her same neighborhood, but why didn't she come to me? Well, our pediatrician had just never referred her. So it's not always where you live or the access, but what are the networks of care? And sometimes it's just good luck or advocates. You get lucky if you're born in Birmingham, maybe not so lucky if you're born in Selma, Alabama, where there's no specialist. Well, that shouldn't mean you get worse care. So we have to shift that programmatic emphasis and figure out how we get care to people as opposed to always thinking about how to get people to care. So we have this multi-system chronic disease. It's very complicated. People have complex health needs. They require not just medical providers, but social services. And really, they require the whole ecosystem of care, including, as we just heard, physical therapy, physiotherapy, as you say, psychology. They require nutrition. If we ever get that available in the US, I will be thrilled. But it's a complex disease, and it presents a different system. This is different than my 40-year-old who ate too much McDonald's and comes in with a heart attack, right? Your 40-year-old with sickle cell is not the same and should not be treated the same way. So what about a new model of care? Well, the medical home was sort of started by primary care. And it was started because even primary care in the US especially started to realize we're not doing a very good job. We're not making sure that people are connected to all the different care areas that they need. And more importantly, as I mentioned, it's this very consultative model. So as the primary care doctor, you might not know what happened if they went to the surgeon or if they went to the ear doctor. That's still true. We're really, really bad at talking to each other. But at the same time, if you have a central person coordinating that care, more information gets back and forth. And that's where this concept of a medical home came from. And it's really the primary care in the middle and all the specialists on the outside. Well, why can't we adapt that model to sickle cell disease? It's truly what our sickle cell center is. It is a specialized medical home where the sickle cell center is in the model. Now, the primary care doctor's still there. They're just more on the outskirts because the central part is their sickle cell. We still want them to see their primary care doctor, but they're almost more of the consultant in this scenario. So we called the specialized medical home the same thing as a sickle cell center. And we said we want to enhance care by creating these specialized medical homes, by making sure that if you're in my hospital, you get the same care, the same pain regimen that you get in my clinic as you do in the ER as you do in the hospital. So it's a horizontal practice, but also a vertical practice. So we make sure that everyone gets those same care wherever they are. We want to make it sure it's longitudinal, it's continued throughout the lifespan. So if I'm going to change your care when you're 18, you're going to look at me like I have horns. Most of the 18-year-olds look at me like I have horns anyway, so I didn't need that help. So we need to start seeing those patients earlier. So we start saying, okay, if we're going to change your care, let's do this in collaboration with pediatrics. Let's coordinate the education, deliver the same messages, and provide mentorship so that we can create more doctors that treat sickle cell disease. So where did we start? Where it turns out, if I just walked over to my hospital and said, I need a sickle cell center, and I need this, this, and this, they would be like, yeah, with what money? Or why do you need that? You know, it's not lucrative to us. Or what are you going to show me for that? So you had to build something to show the data. But more importantly, unfortunately, you just needed it on paper. So I took my patient, going back to my patient for a second, and looked at her, and she'd been hospitalized 5 times in the year. She'd been in the ER over 20 times that I could find records for. A lot of crisis, felt like she could barely leave home because she was scared she'd have pain. She tried to go to college, but it didn't work out, and she had a child. She was separated from the child's father. So going back then to the C-suite, because I took this patient and I said, I have patients like this that need everything, and I can't do that unless it's all in one place. And the C-suite said, we don't care. What they really said was, put a business plan together. And I was like, wait a minute, I went to medical school, not business school. And that's actually what they expected of us. So we all got together and said, we need to do this together. And if you're going to say, I need a sickle cell center, you needed to say what a sickle cell center is. Because there wasn't anywhere on paper that you could look that up. So that's where that paper came from that we talked about just a few minutes ago. We said, we're going to create this. It has to be the recognized authority. That means that I say how much Dilaudid, for example, my patient gets if they come to the ER, not the ER doctor. I have to be the authority for blood transfusion for people with sickle cell in my hospital if I'm leading a sickle cell center. And if you put that on paper, then it turns out that your C-suite's more likely to believe it. And if you say you can't be a sickle cell center if I don't have all these things, that starts to get a little bit more exciting. So he said you had to be able to provide all disease-modifying therapy. You had to be able to do blood transfusions. You had to have an iron overload program. Importantly, you could not consult out your pain management. You couldn't say that I'm going to be a sickle cell doctor and I'm not going to treat pain, because it's too much of a part of what happens in sickle cell disease. So while you could bring a consultant in to treat pain, you as the sickle cell center couldn't say we're not going to do this as part of what we do and one of our requirements. And then there were all the adjunct opportunities to do telehealth, to build a hub and spoke model, to have extended hours, to have a day hospital that didn't have to be required. And that's really where this came from. And here my formatting got messed up too. What this came from was we want everything in that circle. We, the sickle cell specialists in the world, believe that everything in that circle is absolutely necessary and required. We know we're not going to get everything in that circle, so we wanted to say, what is the bare minimum to hang your shingle up and call yourself a sickle cell center? And that was with the middle part. And I can't tell you how many people now take this paper to their C-suite to say this is what you have to do. It's been very transformative in that way, and it's time to redo it, to say now we've learned more, and a pharmacist is really integral into what we do, and we need that pharmacist, and they need to move into the middle of the center, because that's how we make change. We put it on paper, we say now everyone else has to do it, and then we put quality metrics next to it, right? Then we say you're not going to be a qualified center if you don't do that. Our pediatric colleagues said, wait a minute, you're not alone in this, we need this too, where's our list? Because this is really based on adults. But pediatrics actually had even more requirements. Why? Because we know more about pediatric sickle cell disease. So they required that apheresis was available, whereas we required transfusion was available, but not specifically apheresis. They required that you had sickle cell education liaison in their center. So a little bit different, but still similar. But again, we said just defining this isn't enough. We have to track outcomes, because a lot of people say they're going to do something, but how many got that something done? And then did they do it well? The truth is we have to not just track outcomes, but be very transparent with those, and be transparent with our communities and what they want to know, not just what we, the providers, want to know. So that's a plan for comparative quality assessment. So we said, okay, we need a national approach. We can't just do this on a center-by-center basis. My good friend Wally Smith used to say, if you've seen one sickle cell center, you've seen one sickle cell center. Unfortunately, you don't know Wally as well as I, but I cannot do his voice at all. But I hated when he said that, because I said, it shouldn't be that way. We should actually do the same thing so that people can expect if they move from your center to my center that they get the same care. So how do we nationalize that approach? In the US, I call this my Hamilton slide, because if you've seen the play Hamilton, he says, are we a nation of states? What's the state of our nation? Because often, like you all are a nation of provinces, we're a nation of states, and we don't act collaboratively. So how do we change that? How do we do that? How do we get the infighting to stop? All these different groups who wanted to do their own thing, and their own thing was the only thing that mattered, to work together. It turns out you just say you're going to do it. So when we started the National Alliance of Sickle Cell Centers, people kind of rolled their eyes at us at times. That's not going to fly, it's not going to work, or you're never going to get enough people to get along with you. Because people just don't get along. And the less money there is, it turns out the less people get along. Right? If there's plenty of money for everyone, then there's no reason to fight. If there's not enough money, everyone's fighting. And that included fighting for data. So why don't we have enough drugs for sickle cell disease? Because we don't have enough data about sickle cell disease. We've never continuously collaborated to collect that data in a meaningful way. And that was because all these groups were fighting. So we said if we're going to form this alliance of centers, we have to get all of them to commit to collecting data. Because we can't move this needle without that. Commit to comprehensive care, commit to collecting data, and commit to your metrics being checked. Realizing that my percentage of adults seeing an ophthalmologist every year was 29%. Hopkins was 62%. So the question is, why are they doing better, and what do I need to change, and how can I learn from them, as opposed to the idea of a finger pointing, you're doing a bad job. Well, I am doing a bad job, so how do I do better, and how do I make sure that that's something everybody understands? So this is the real Janelle, even though her name is not Janelle. She's now, I think, a couple years younger than me, so in her 40s. She did restart her hydroxyurea. She had access to our sickle cell center. She had the ability to get infusions. We decreased her hospitalizations and improved her life tremendously, but not as much as we wanted. And then crizanlizumab came along. She actually was on the SUSTAIN study. And 2018 was still the last time she had to be in the hospital for sickle cell disease. And that was all about access to comprehensive care and therapies, and really the beauty of needing a sickle cell specialist. So how do we make sure this doesn't happen? We all start saying from the rooftops, everybody living with sickle cell deserves access to a sickle cell specialist. Our governments need to hear it, our policymakers need to hear it, our stupid insurance companies in the US definitely need to hear it. And we need to make sure that we're saying it out loud and often, until we have enough doctors and providers and people to care for this population that desperately deserves the care that they need. We have a map of centers, very similar to CanHEM. We do have now 120 centers, which is amazing to say that 120 centers are going to actually get along. They mostly get along. I'll tell you more about that tomorrow. And then we have to identify the leaks in the system, because nothing's foolproof. So yes, we've made headway, but we're not there yet. We've just put the system in place to start making progress. So this is a map of our centers. It's about 15 centers short, because I downloaded it a little bit ago, but you can see it online. And I'm going to get to tell you a little bit more about what we've done as a group of centers, because we have defined what a center is, And now we need to do what we call developing a community of practice, or practice harmonization. We need to start treating sickle cell similarly so we can better understand our outcomes. But you're going to have to hear about that tomorrow morning. So, we reviewed the old model of care, the pediatric and adult consultative model. We talked about some of the historical barriers, and we identified a new model of care, and I at least got to introduce you to the Alliance that I'll tell you more about tomorrow. Thank you very much.
Wow, let's give Dr. Cantor another round of applause. That was brilliant. Now to the questions. Questions for Dr. Cantor or Dr. Verhofstadt from the crowd. If you have a question, you can raise your hand and I'll come to you.
Yeah, she's coming.
I'm coming.
Thank you. Wonderful presentation from both of you. It was amazing. My question maybe not so much directed into comprehensive care, but where does research fit into all this? And definitely, like in Canada, the research for hemoglobinopathies, I should say, is in 2, maybe 3 centers, but I think we need to expand it to include more centers. That's probably, you know, same in the US, but because of the geography, you have many centers.
Yes.
So I think that's a great question, and it's actually been a heart of the problem in that people have prioritized research over clinical care. And that has led to some of the problems. So in the US, we had this NIH Comprehensive Sickle Cell Centers kind of before my time. So it prioritized the research, but then when the grants went away, there was no network of centers anymore. So we're hoping by flipping this, that we can change that. If we can deliver more comprehensive care, those are more people who are already collecting data and have that in place to now be able to do more research. And it helps the researchers, because if you're doing a new clinical trial, you want to make sure that you're giving your drug to people who are getting a similar method of care. And that way you can really test it more accurately, which we also weren't doing. So we felt like we had to take a step back from the research to make sure we put clinical care first and prioritize people's well-being, and then could add research on top where they also knew that we were here for them and not the research. But we also know that by putting that clinical structure together that you'll have more research opportunities. So we're working now with the American Society of Hematology, who has the research side of this, to say, okay, now we've put this kind of underneath, how do we put research on top to expand it to more people?
Thank you. Thanks for that question, Riyadh. And thinking about our Ontario context or in Canada, I mean, this is such a huge topic because, you know, when many people think about research, they think about, okay, what are the new therapies that are coming out and how are we going to get these, you know, in people's hands and see if they work and see if they're safe. And I think that's happening in a few key centers across Canada and needs to happen more. And most of that is led by pharmaceutical companies and funded by pharmaceutical companies. And I think a lot of times there are factors that determine which centers can be the centers, you know, that there has to be a certain number of people who may be eligible for it to be worth their time, in a sense. So some of that is going to be addressed by developing the centers and bringing the patients together, as Dr. Cantor said. I'll say as well, though, that's not the only research we need. We need clinical services research that's looking at models of care and what works best and what works well and what doesn't. We need, I'll shout out to the CanHEM Registry Initiative. We need just to be able to understand, is it 7,000 people or is it 8,000 or is it 10,000 people living with sickle cell in Canada? We don't have that information because we don't have proper ways of collecting that data. It's even harder with the way data are coded in Canada to enumerate the number of people living with sickle cell. So thinking about we want to, there's so many levels to it. We want to stimulate interest in future researchers to come into hemoglobinopathies as their focus. There needs to be a support structure for them to, okay, they've got a keenness toward research. How are they going to translate that into a career where research is part of their career? There needs to be funding mechanisms for research that's not just the pharmaceutical companies, so whether CIHR and other bodies. And I know there was an excellent paper, I think J.J. Strauss was one of the authors, comparing funding for cystic fibrosis to sickle cell research, and it was orders of magnitude higher per patient in the United States for cystic fibrosis. So recognizing that we need to be advocating for the organizations that fund these things, and also, you know, patient organizations do a really great job of stimulating research opportunities as well. So it's a huge topic, and to your point, just developing the care pathways. If we're not advancing care and always striving to do better, the research is a key component to that.
Thank you. Any other question? I thought there would be a lot of questions. Over there? Wonderful.
Hi, I'm a genetic counselor. There's a shortage in Ontario, I'm sure you know. In the over 20 years I've been practicing, I've only ever had one person living with a hemoglobinopathy come to me for actual genetic counseling during pregnancy and such. Most of my population is the new carriers that are being identified incidentally. I'm just curious how genetics fits into this model in Ontario, the Ontario model.
Okay, I guess that's for me. Another huge topic, and I'm not sure, I mean, what actually comes to mind for me is the newborn screening program and the fact that those results aren't proactively being sent out for carriers, which in our current shortage of genetic counselors, I think that was one of the main things holding that back, is that it's not resourced to be communicated out in a robust way to the families. I think more info to come from SCAGO on that in the weeks, months, and years to come about advocacy on sending that information out, because right now we've got many thousands of people 18 and under living in Ontario who have sickle cell trait and don't know it or may not know it, but that information is available at Newborn Screening Ontario. That was not, however, I think your question. I think, you know, a lot of this information, if I'm honest with myself, it's not part of the core competencies of a primary care provider, but it can be. You know, this is pretty basic autosomal recessive inheritance patterns, and with the right tools and information, that information can be communicated out by other care providers. It doesn't necessarily always need a genetic counselor. I know in our hemoglobinopathy clinic, so in our sickle cell clinic, we'll usually take that on ourselves. We'll encourage them to bring in a partner, send them off for the hemoglobin electrophoresis, and then we'll do that deep dive on what that means for them. So I think there are a number, it doesn't all have to fall on genetics clinics, although in an extremely well-resourced setting, that could be excellent. And I think it probably needs a little, like, bringing everybody together from the different perspectives across the province. I'm looking at Jennifer again. She's taking notes. I hope it's about this. Jennifer Bryan. I think this is something that we should look at provincially and sit down with representatives from primary care, from the genetics clinics, from the hemoglobinopathy clinics, from Newborn Screening Ontario, and say, okay, where are we at? Where are the gaps? How do we make this work with the resources we have, and what extra resources need to be brought in?
And two thoughts on that. One is I don't know how newborn screening results necessarily get disseminated. We don't do a very good job even in the United States. We do a good enough job, and what I mean by that is I think 90% are really well done, and so people forget about the 10% that are not. And I'm actually talking about people with sickle cell disease. but I know that we have also had the same shortage, not just of genetic counselors, but I think of motivated humans in general. And so what are, at least in Alabama, but in several other states in the Southeast as well, our community-based organizations now get those results. So what happens in Alabama is it's all divided out by region, and the trait, people with sickle cell trait get to the community-based organizations because there's no way, we don't have enough time to take on that role as providers. So they actually get funding from the state to do that counseling, and some have their own genetic counselors. And I think there's a huge role for that that I think can be translated elsewhere. In my ideal world, I would absolutely also have a genetic counselor available within my sickle cell center. The issue has become, for us, worse at the moment in Alabama. What do I do? Do I tell someone not to have a baby? Do I tell a couple who love each other not to have a child? And I have trouble without having a good answer to this question with putting people in the framework of making this decision. What about abortion? How does that fit in? And when does it fit in? And I'll tell you a quick interesting story on this. My story comes from Cuba. Many lifetimes ago, it feels like I went to Cuba. This was that short period where they had really opened borders. And you don't know much about Cuba, none of us do, because very little publications get to leave Cuba. They have an amazing healthcare infrastructure and system. It turns out in Cuba, if you're a mother and you find out that your unborn child has sickle cell disease, you can have an abortion, no questions asked. I'm not telling you I think that's the right thing to do, but I'm telling you that it's amazing to me that there's a country that gives a choice and that gives that counseling, so they get the counseling before they ever have the child. They also get the counseling on what education and treatment looks like for that child, long before a lot of people in the United States do. What they found, interestingly, so their newborns with sickle cell disease have gone down significantly in Cuba. This was in 2018. And again, I think there's rights and wrongs to this, so I'm not getting on that platform. But what they found that was fascinating was that most mothers would have the baby, but if they had a second child that they found out they were pregnant with another baby with sickle cell disease, that they would not often have that pregnancy. And I think it's something that should at least be evaluated, because I think everybody deserves choice now you know my political stance. But I also think on the flip side of that, and the UK has now embarked on, if you already have a child with sickle cell disease, you can have IVF for your second child. So now the UK will pay for IVF. And again, that's the ideal, right? If you have a loving couple that want to have a baby, I don't want to make you consider terminating your baby. I want to make sure we can help you have a baby that doesn't have sickle cell disease. But that means IVF has to be paid for, which it's not in most plans and countries. So that was a very interesting finding I learned from the UK. And so when they complain, they're like, yeah, but it's triaged and there's only a few that they'll let us do per year with the NHS. And I'm like, we don't get to do any IVF via Medicaid, so sometimes count your blessings. So I think there's a lot of really interesting ways that if we had more options, we could involve genetics a whole lot more.
And if I may add to that on what is going on in Canada here. So Ms. Rugi, you're here in the room. So when we saw the flaw in the newborn screening program in Ontario, whereby even though babies who have sickle cell trait are flagged, but they do not automatically disclose that to the parents. When we were doing newborn screening for Atlantic provinces, we made sure that both sickle cell disease and sickle cell trait are flagged. And the beautiful thing that the government did in those provinces is that they pair telling the parent about their baby's sickle cell trait with counseling, so that the parents know the sickle cell trait is not a disease and for education purposes. And I think BC also has a similar program, and Ontario have to get it right. And tomorrow there's a presentation that I'm speaking on sickle cell trait screening in Canada, right? So comparing and see what works and what still needs more work to be done. So I really think, to your point, genetic counseling is a big part of everything, and it should be incorporated at some degree. Do we have? Okay, we have. Sure.
Not telling folks that they have sickle cell trait can be very crucial. My sister has sickle cell trait. She takes hydroxyurea, so she's way up past sickle cells. And met this guy, gentleman, who is also, we're from the same country, but they met in Edmonton. I said to you, she's actually here, not here, but she's at my place. So they got married, and straight off she said, I have sickle cell trait that's so high, so I can have a child with sickle cell disease. And the gentleman said, but I tested, they didn't get back to me. I don't have sickle cell trait. He assumed that because the hospital didn't get back to him, he doesn't have sickle cell trait. So that's confusion sending to people. I don't get a call, I'm okay. The same thing, you go do your other tests, the doctor would say, if you don't hear back from us, you okay. So that's very confusing. That caused a riffle in that relationship. My sister said, no, he lied to me. I said, he didn't lie to you, it's a system. I had to come in the middle, just a story to share that I was part of it. Meaning that it is very essential that if somebody has sickle cell trait, they should know, and the education starts. Thank you.
Thank you, Ruji. I'll just make a quick comment about that. I was speaking with the executive director of the National Rare Blood Disorders Group, and in that organization, and in that conversation with her, I said, I can picture, we now have these patient platforms for getting your results, but hemoglobin electrophoresis, which is the test to screen for sickle cell, can be confusing to interpret if you don't know what you're looking for. I'm kind of picturing a day where we're at a different, version 5.0 or 8.0 of the patient platform, where there's just a section with, what's your status? Do you have thalassemia trait? Do you have sickle cell trait? And someone can just see there, because it's really a test that each person should just have done once in their life, with rare exceptions. Sometimes we do it multiple times for somebody on therapy, but if it's just for carrier screening, it just needs to be done once in someone's life, and then it's just known thereafter. So that would be a good example where if he had had access to his own patient platform where he could just look that up. Yeah, Julie?
I was just going to add to that, this has come up in numerous ways recently, and what's very interesting to me, and I don't know what kind of medical record systems you all are using, but here we're in this day and age of all these electronic medical record systems, and there's no place it's interesting in the system for genetic conditions. And if you had that, then your newborn screen, at least it could go somewhere. It could live somewhere that could at least get perpetuated. So I think in this day and age, there's ways to do this technology-wise. We're just not doing it.
Thank you very much for the really inspiring presentations. I was just wondering, there's a hidden burden of emotional disorders, mental distress with sickle cell. Some of it's hidden, some of it's overt. And do you have models of mental health support within your centers? And if so, what can we learn from them? Thank you.
The absolute best models of mental health support, I'm going to kick this over back to the UK. The UK really, I probably hold them on a pedestal higher than they think they belong on. But the Sickle Cell Center that's about the size of ours, that Joe Howard used to run, it's now Rachel Kessu and a few others, they have 5 psychologists. And they really have the best, if you want to study good mental health care, that's where you go. On a good day, I have 1 psychologist for 800 people. And that's on a good day. And so we are not the model. We would like to be. We do not, as a country, in any way, shape, or form, unfortunately, prioritize mental health in the way it needs to be prioritized. And I think there's 2 levels to this. One is we need to demand better for our individuals living with sickle cell disease. And 2, we need to talk to our individuals and understand what they want, because there's also significant stigma around the concept of mental health care. And I think that's true everywhere, not just in our world of sickle cell disease, but I think it's so crucial because anxiety and depression and pain all go hand in hand. And so we can't fix pain if you have horrible depression and anxiety. No matter what we do, your pain and anxiety won't get better. So absolutely important, but if you want to see what works, go to the UK.
I don't think I have too much to add. I'll say for over 500 patients in our program, we have Sarah Rashid, our fabulous social worker. She's a social worker who also happens to have counseling credentials, which she applies every aspect of her skills across our lifespan clinic. But I can guarantee to you, every single day she's wishing we had 1 or 5 psychologists on our team, and it's a huge gap. I was just trying to give Julie a crash course in OHIP and what's covered and what's not, and the fact that, for the most part, psychotherapy is not covered, with the exception of some psychotherapy that either happens through a psychiatrist or at the primary care level, but it's a huge gap, and it's something that we as providers and as community advocates need to really focus on. So thank you, Oyedeji.
The other thing I'll add to, similarly, what Medicaid pretends to cover for psychology is so poor that psychologists and psychiatrists don't accept Medicaid in most places in the United States because it's literally not, filing the paperwork isn't worth the money. So they just unfortunately won't accept the individuals. So that's why we've actually put it into the center and said we can't rely on outside sources. We have to embed counseling and social work and psychology within the centers themselves and figure out how we get our systems to then fund it. And a lot of that is trying to explain the return on investment might not be in dollars, but it might be in less acute care. Because if we can improve depression, then you can make people feel a whole lot better. And so those sorts of arguments are how we're working on it long term.
Yeah, thank you so much for the great information. You guys have given us an amazing presentation. Now, maybe this might sound a little bit ambitious, but I know the genetic clinics have been doing a very great work in terms of diagnosis and some bit of genetic counseling. But in a perspective of clinical research, genetic research, are there some advancements in terms of gene alterations to find a cure for sickle cell, or we just have to continue with conservative treatment?
Can we save that question for tomorrow? Because I'm going to talk about it in gene therapy. It's too long an answer.
Bottom line, huge advancements happening, and hopefully coming to Ontario soon.
Thank you. You will all agree that this has been an amazing first day of the summit. Thank you. But before we close the day, I want to ask 2 of you a question each, if that's okay. For Dr. Kenter, from your presentation and the comprehensive model that you have presented from the US, are there specific aspects of that model that you think can be replicated anywhere in the world, whether it's low resource or high resource country?
That's a great question, and it's interesting. I have lots of people say, "Why are you not doing more in Africa?" To which my response is always, "Because I have a lot of work to do in the United States first." Right? If we can't fix it in a high resource area, how am I supposed to make things better other places? I think the concept of care coordination and what I call one-stop shopping, that you can come in to my clinic and see a primary care doctor and a social worker and a sickle cell specialist all at once, is a significant decrease to patient burden in a way that I don't think we always imagine. And that's something I think we can replicate anywhere. I think when we add in what may be upcoming new and novel point of care diagnostics that won't rely on central laboratories, that will even make that better. But I think having doctors in one place decreases the burden on the individual to try to get to all of those different people.
Agreed. Thank you. And to you, Dr. Verhofsek. Yeah, let's do that. So being a part of the Ontario Hemoglobinopathies Patient Association, which developed the 3R document, how do you think that this document can be replicated to support advocacy for more comprehensive centers across Canada? Thank you.
That's a great question, and in fact, the outgoing president of CanHIM is waiting for our finalized updated document to try to use it as an advocacy tool in Alberta specifically. So I think Ontario, because we have been on this journey for a while now in partnership with the government in a way that is a few steps ahead of some of the other provinces, I think our colleagues in other provinces are looking to us to be able to replicate some of that, and there's no need to reinvent the wheel. If we've developed this document, it's been tested and revised over the years to reflect the current state. There's no reason we can't share that with the comprehensive care center leads, with the patient organization leads across the country, and get their feedback as well, too. We want to be thinking about what can we learn from them so that it's not all just Ontario-centric.
Thank you. And on this note, I'll ask everyone to please give a round of applause to Dr. Cantor, Dr. Verhosek, and to yourself for being here today. And so, we made it. This is the final session and the end of day one. We'd like to thank our sponsors again. Without Novo Nordisk, Vertex, KSC, Pfizer, Canadian Blood Services, we won't be able to hold this summit today. So we want to thank all of our sponsors for being generous of your financial support. We thank you for being here. We want to thank our volunteers that supported to make today happen. We want to thank you, our attendees, for being here. We could have the food, we could have the speakers. If we don't have you in the audience, who are we doing this summit for? So we want to thank every one of you for your participation, and we look forward to seeing you tomorrow.